moving towards our sixth topic. Heart failure is a very severe complication of diabetes. Early diagnosis and treatment may help relieve symptoms and slow down the conditions from worsening. On World Heart Day, to focus on the topic, heart failure in diabetes, clinical suspicion is the key. We have an eminent speaker with us, Dr. Sunip Banerjee, interventional cardiologist, Kolkata Heart Lung Center, former associate professor of cardiology, PGI, Chandigarh. And to chair this particular topic, I would like to invite Dr. B.P. Pandey, senior interventional cardiologist, HOD Department of Cardiology, Narayana Super Specialty Hospital, one of the founder member of Howrah Diabetic Society, Dr. Shubhanan Rai, a renowned interventional cardiologist, director cardiology, Fortis Hospital. He is the innovator of the technique nanocrush stenting used for treatment of coronary bifurcation. Dr. Ashok Malpani, one of another renowned interventional cardiologist, and Dr. Narayan Bhattacharya, senior medical consultant cardiologist, formerly associated with Command Hospital. And I will also request to chair this session, Dr. M.L. Bansali sir, one of the founder member of Howrah Diabetic Society and senior medical consultant, to please chair this particular topic. Dr. M.L. Bansali sir, to please be there and introduce our eminent speaker.
With a heavy heart for Howrah, good morning to everybody. And as you all know, that heart failure is very, very important and pertinent topic in today's world. And I think heart failure is the final common pathway for so many diseases like diabetes, diabetic heart disease, hypertension, and valvular heart disease, and other chronic illnesses also. So diabetes is almost associated. If we see 4 heart failure case, one of them will definitely have diabetes, and we see 4 diabetes case, one of them will have heart failure. And for that, we'll be enlightened by speaker like Dr. Sunip Banerjee, who doesn't need any introduction, I think. And without wasting any time, I will call Sir Sunip Banerjee to enlighten us.
Thank you. Please get the screen. Can we dim down some of the lights? So I think in this conference you have heard many molecules for heart failure, particularly in diabetes. There are some medicine which are good for diabetic patient to prevent fast hospitalization. But beyond all of these, the most important thing is you need to diagnose what is heart failure. And we think we are missing somewhere in diagnosis heart failure. What I am going to show you, probably in today's scenario, the young people are busy in the back in their mobile, so I don't know whether they have been taught this thing or not, but 40 years back probably we have gone through these stages, and we didn't know actually what is heart failure. Because when you go through this depiction, it's just like remembering these points and face the MCQ. So these are really the same story which is for last few decades has been there as a diagnostic criteria of heart failure. And what is most important, you need to understand that few things we are seeing more commonly is the fatigue, tiredness, and increased time to recover from the exercise. And this is really has been observed recently. There are certain important clinical signs which I am going to discuss or show you today. And less typical and less specific signs are all these things but none of them are less important. So if you have to understand and realize that you are on verge of picking up a case of heart failure, you need to keep all this point in mind, and just in one day, 5-minute session, you cannot be able to remember this thing. Let's recapitulate some basic issues which we still miss, but these are important. Can anybody tell me what is the difference between this symptom? Both this patient are diabetic. One of them takes inhaler and gets up at night with bouts of cough followed by dyspnea. And another person is getting up, he is getting dyspnea followed by cough. And probably we need to understand the first one is more of a bronchial issues. It may be a reactive airway disease or asthmatic bronchitis, whatever you say. So you get cough and wheeze, and followed by you get dyspnea. But if it is a PND, you actually need to wake up with a breathing difficulty, and when it becomes too much and you feel relieved by a cough. Now, why this is important? Because in today's scenario, most of these patients are already on guideline directed medical therapy or half therapy, some diuretic, some vasodilator. So we don't get a very clear state books picture, but this important clinical clue you need to keep in mind. Patient with previous ill-treated pulmonary infection, be it pneumonia or sequelae of recurrent respiratory infection, you can get bronchiectatic changes. We have seen interstitial lung disease so commonly happening in the country. So there may be some people with crepitation, but this is a misconception. This doesn't mean that he has a heart failure. At the same time, when a patient presents with acute LVF in an early stage, you can get a bronchial edema and you can get lot of wheeze, and misconceptually, if you fail to understand that this patient has an acute pulmonary edema impending, you unnecessarily give salbutamol and increase the heart rate rather than giving the diuretic. And these are the things which we need to understand. Coming to the issues of diabetes and heart failure, diabetic patient can heart failure usually because of a heart attack which has been missed. So this is a bad thing. So there you need to do whatever different thing is. But there is truly a concept where the coronary arteries are normal, diabetes long-standing or even short-standing, and patient present with heart failure. So European Society of Cardiology last year has come up with the basic researcher. They have found that actually diabetic patient can have heart failure because of small heart, which is called a heart failure with preserved ejection fraction, a restrictive phenotype, and they have more of hyperglycemia and more of microvascular dysfunction and insulin resistance and hyperinsulinemia. On the other hand, who has a heart failure with reduced ejection fraction and a dilated phenotype, they actually don't need much insulin, and there is more of advanced glycosylated AGE product. Now, why I wanted to choose this topic? Because when you call heart failure, you actually look into elevated natriuretic peptide and echo and you diagnose heart failure. No, it's not the way to do it. Heart failure is a symptom and signs caused by structural and or functional cardiac abnormality, and that has to be corroborated with objective evidence of cardiogenic pulmonary or systemic congestion. Why objective? Subjectively, if I am not doing any work for 7 days and suddenly I started doing some activity, I will feel out of breath. So that is a subjective evidence. Sir, amar shaskosto hocche, ঘুম হচ্ছে না রাত্রে, বোধহয় আমি হার্ট ফেলিওর হচ্ছে। নো, ইউ নিড টু হ্যাভ এ অবজেক্টিভ এভিডেন্স। So in next couple of slide I am going to show you what is called objective evidence of heart failure, and why in patient with diabetes it is important, because of this presentation which was there, copied from a heart failure conference 5 years back, and which shows the mortality and risk is very high, and it's actually not related to the control of diabetes. If you have a good control, then also you can have a very good incidence or prevalence of heart failure. And obviously when it is terminal, you will have heart failure because you have uncontrolled hypertension, you have renal dysfunction and many more things. Now why this slide is important, because there are some history mentioned and some clinical sign mentioned. Now all of them are not important. Like dyspnea is very specific, so at the same time its sensitivity is less, because I said that if I am deconditioned, if I am anemic, I may be dyspnic, or if I am taking if I am recovered from a febrile illness, I may be asthenic. So that's sensitive not, but it is specific if you pick up rightly. Third heart sound, bilateral peg edema, they are again very sensitive, but they are not specific to heart failure. So most important till now is the heart failure specificity lies in the weight and jugular venous distension and cardiomegaly. But if you have a heart failure with preserved ejection fraction, normal left atrium, you will not have a cardiomegaly. So actually jugular venous distension is a very important sign in heart failure diagnosis, and in patient with short neck you may miss it. Before that we need to talk to the patient. I will just share few discussion.
क्या तकलीफ हुआ था जिसके लिए आप डॉक्टर साहब के पास आए, उसी के दौरान आपका?
हाँ, तो डायबिटीज़ कितने साल से हैं?
डायबिटीज़ करीब 13 ईयर्स से।
दवाई क्या चल रहा था?
दवाई पहले कई दवाइयाँ खाया, सब डायबिटीज़ का बराबर, जब डॉक्टर बदलता भी रहा।
ठीक है। शुगर कंट्रोल में रहता था?
शुगर उतना, जब से आपकी दवा खा रहे हैं तब से शुगर में एकदम बिल्कुल कंट्रोल में।
उसके पहले नहीं था? अच्छा, प्रेशर
की दवा खाते थे सर।
ठीक है।
हाँ, प्रेशर।
और तम्बाकू
वगैरह नहीं खाता।
हाँ, वो क्या हुआ था भागलपुर में?
वो अचानक मेरे सीने में दर्द शुरू हुआ।
हाँ,
और उसके माथा में चक्कर आने लगा।
हाँ,
तो उसके बाद हम फिर वहाँ से भागलपुर से कोलकाता।
नहीं, भागलपुर में तो 4-5 दिन थे आप?
हाँ,
कि 7 दिन?
वहाँ पर डॉक्टर को दिखाया तो लोग नहीं कर पाया।
हाँ, 7-8 दिन। नहीं, अब जो भी हो, वहाँ पे रहने से जब आप यहाँ पे आए तब आपको तकलीफ क्या हो रहा था, याद है?
हो रहा था, हमको सांस लेने में तकलीफ हो रहा था। और अनरेस्ट पूरा, फिर नींद हमको एकदम बिल्कुल 2-3 दिन पहले से नहीं आई थी। 2-3 दिन से मैं सोया नहीं था।
और खांसी
था, हल्का था।
हाँ।
खांसी बहुत ज़्यादा।
और पैर में सूजन?
पूरा शरीर में स्वेलिंग हो गया था।
अच्छा। और उसके बाद आपने हॉस्पिटल में दाखिल हुआ, जो एंजियोप्लास्टी वगैरह हो गया। ये what is important to know in this discussion, may not be very clear audio, is that this patient has a big gastric discomfort and mild elevation of lipase amylase, and the ECG has been performed by a technician and it is reported after 3 days, which shows the inferior wall myocardial infarction with a complete heart block, and then he came with a heart failure and anti-diabetic medicine, as you saw, he was taking irregularly, and he was taking a combination of pioglitazone and metformin. I am not going to blame any of them, but these are the clinical clue which will help you. And also another important thing is this patient who is
18 সালের সেপ্টেম্বর মাসে আমার মানে তার আগেও কদিন ধরেই একটা অস্বস্তি হচ্ছিল। আমি অনেক রাত্রির অবধি জানতাম, টিভি দেখতাম। তো টিভি দেখতে দেখতে আমি একদম পুরো মনে হতো দুম করে পড়ে গেলাম, বিছানার সামনেই বসতাম, বিছানাতেই আমি পড়ে যাই। এটা কিন্তু বেশ কয়েকবার হয়েছে। তা সেদিনকে ওটা 8 তারিখ সেপ্টেম্বর 2018, ওই দিন সকাল থেকে প্রচণ্ড লেথার্জেটিক লাগছিল। তা আমি কিছু ফিল করিনি অসুবিধা হবে, আপনি ইমিডিয়েটলি ভর্তি হয়ে যান। এইসব শুনে রাত্রির 12টার সময়
So he has been advised to get admitted because of a troponin I, and the only symptom is single episode of syncope and extreme fatigability. And both this patient, the first and second patient we received, has infarct heart failure. And this patient, being smoker, physically less active, presented with florid pulmonary edema. Now coming to a very important and the focus topic is examination of this basic thing which we used to learn in our MBBS days, and we had to lean forward with a tool to see what is happening, and we probably hardly make anything. Now you need to understand very clearly that there may be patient who has hypertension with a heart failure. So how you recognize which one is cardiac pulsation and which one is venous pulsation? So if you observe my thumb, it's just having a pulsation which is very regular, and that means this patient has actually a hypertension of long duration, adequate control of heart rate because my carotid pulsation is not very fast, and this is the jugular vein which is showing A and V wave. So most commonly we can see A wave and V collapse. We cannot see the other, but the important thing is you should not miss this JBP. And this patient with this jugular venous distension, if you see very carefully, you can understand that this patient is having atrial fibrillation because the jugular venous distension is prominent. There is rapid drop which is called a VY collapse, and it is irregular. So it's not like that from JBP you diagnose AF, but you can see very clearly from this. Next is some people may not have resting jugular venous distension, and so you have to do something which is called hepatojugular reflux. So you have to press your upper abdomen very slowly without allowing the patient to know that you are giving a compression in the epigastrium or right hypochondrium, and then you can make the JBP very prominent. At the same time, you need to understand that this patient who has come up with extreme fatigability and NT-proBNP raised and a complete heart block, and this is called a cannon wave. Why it is called cannon? কামানের গোলার মতো মাঝে মাঝে হচ্ছে, and why it happens? Because the atria and ventricle are being dissociated, and they sometimes simultaneously contract, and then you get this cannon wave. So cannon wave is sudden significant surge of a venous distension. Clinically, it is also possible to find out a apex, and you can see my index finger is being moved, and the place is left 6th intercostal space just outside the mid-clavicular line. So this is cardiomegaly, which is not uncommon to see in the clinical practice, and if you practice this thing, you will enjoy this subject. This is a patient who has a long-term heart failure with cardiac cachexia, and you can see this right ventricle is introing. This is a rheumatic heart disease. Patient is having jugular venous distension, cardiac cachexia. This is again a patient where you can see the severe tricuspid regurgitation, which has been manifested as a pulsatile liver irregular. So again, this is a sequelae of not mitral valve disease, a severe anterior wall myocardial infarction where the septum has become scarred and patulous, and the RV has been dilated, and you can see very clearly a atrial fibrillation because it is irregular, and a prominent hepatic pulsation. This we have discussed. This is again a patient who has everything, in the sense that he came with a painful gynecomastia, and this is the JVP, and if we can, he has a gynecomastia because of spironolactone use. This is a lady, this is of modern day disease. This picture itself is sufficient to find out what form of heart failure this patient is having. Yes, this patient is having short neck, severe obstructive sleep apnea, diabetes, pulmonary hypertension, and after receiving CPAP and heart failure with preserved ejection fraction treatment, she improved significantly. It doesn't mean that you need to ignore your other finding. There may be some finding which is important, like this patient came in the emergency with a white QRS tachycardia. After cardioversion, we found that he had a anteroseptal MI, and he was having this white QRS tachycardia for a day or so, and the only manifestation was fatigability and breathing difficulty. So the issue is that this is a sequelae of old MI, and we need to understand that MI can present like this. Don't get fooled by incomplete echocardiography, and these are the common echocardiography report which are inconclusive. Ejection fraction around 50%, grade 1 diastolic dysfunction, mild MR, paradoxical IVS. So these are actually doesn't mean that you have really a problem or you don't have. So to end with, to recapitulate the same slide, and this is not uncommon in clinical practice to find some of this, and then to stamp this patient as heart failure. And remember one thing, once you are diagnosing heart failure, the treatment has to continue till the patient is alive, particularly with heart failure with reduced ejection fraction. If the patient is having heart failure with preserved ejection fraction, you need to find out the associated comorbidities, and this clinical examination is going to help you in doing that. Thank you for listening. I just exceeded the time.
থ্যাংক ইউ সুনীপ দা। 30 বছর আগে আপনি আমাদেরকে পৌঁছে দিলেন। 30 বছর আগে বেডসাইড ক্লিনিক মনে পড়ে গেল। আমি আলোচনা করছিলাম যে মানে থ্যাংক ইউ সো মাচ।
Thank you. I just tried to record and thought that the young people should see, and these are all picked up by us, so they should pick up more. But are they picking up? I don't know.
I think the first physician who is treating a diabetic patient will decide the fate of the patient. So when we treat the diabetic patient, how can we think about this heart failure part? What should be the related investigations or symptoms specific to diabetes? There is one terminology called diabetic cardiomyopathy. So is it different somehow from other cardiomyopathies also?
No, this basic science researcher, they have found that diabetic cardiomyopathy in presence of diabetes and no obstructive coronary artery disease, and in MRI if there is no granulomatous disease, amyloid, sarcoid, tuberculosis, those are the true diabetic cardiomyopathy, and they can have restrictive and dilated subgroup. So one of my slide has mentioned it, and in all dilated cardiomyopathy usually the insulin requirement is not there, rather in restrictive cardiomyopathy it is required. So Diabetic patient, first of all, this heart failure symptom may not be evident, but as a diabetologist or a physician, when you treat a diabetic patient, the first thing you say, lifestyle modification and dietary modification. So you will find, sir, ami to kichui khai na, keno? Khele koshto hoy. So that's a clue that if you are having postprandial discomfort, either you have a coronary artery disease or you have a heart failure. Second is, আপনার হাঁটা চলা করা দরকার, আগে তো করতাম, but now I can't do. So this is the very easy pick up clue for a diabetic patient who is having a problem. Now you must do a ECG and a echo, both good quality. If the ECG is normal, there is no evidence of any myocardial infarction, and the echo is also showing normal, then you can subject the patient to TMT or other stress test, whatever is useful. But if this patient is having some telltale abnormality in the ECG and echo, I will not mind to do a angiogram, because obstructive coronary artery disease is most easy to treat, and if you treat them, then you can make them a good life. And that's the best thing, is to do angiogram and exclude it very quickly. Now whether you are going to do a CT angio, probably it is not a good idea to do a CT angio in a patient who is a very elderly one, because you will find low of calcium, and again you have to give contrast for conventional angio. But for a young patient or who is very scared, whose heart rate is not very high, you think, let me just exclude. You can do a CT angio, that's all. It's all patient choice. No, calcium score tells you that the patient has a coronary artery disease. Now in diabetic patient, you need to give statin in most of the cases. Now if you wanted to give aspirin unnecessarily for a possible plaque in the coronary artery disease because of angina, so sometimes you need to stop. The aspirin is not a safe drug. So probably we need to have a very low threshold to do a CT angio or coronary angio, anything, even a subtle symptom, because, and again it comes from this thing, or if you have a strong family history. So guidelines slowly saying that in this borderline high risk population, you do a angio or a stress test which is more sensitive than TMT. So probably keeping everything in mind, you need to exclude first a obstructive coronary artery disease. If it has been excluded major, then you can encourage the patient to do more. That's more practical and feasible, rather than which one is best and where from you can get the maximum conclusion with minimal usage of resources.
How to suspect a silent myocardial ischemia in diabetic patient and do further investigations?
Sir, actually silent myocardial ischemia was a popular topic in areas when the Holter monitoring was initiated and being regularly used in 2000 to 2010 and late 90s. It came up in picture in a big way. And silent myocardial ischemia is a dynamic ST changes in more than 2 lead in Holter with a baseline ECG in other areas. Now the problem is that there has been no further workup has been done over last many years. So how you pick up silent myocardial ischemia, it's really, I have to read and again give you the latest update. But why we are ignoring silent myocardial ischemia? Because many of them will have a manifest episodes of ischemia in between. So probably we take the whole burden, that manifest ischemia and silent ischemia, giving something which is a long acting drug. And that's why beta blocker is the best drug for this ischemic heart disease rather than trimetazidine or nitrate. Long continuous protection.
Do you think that apart from controlling hypertension and diabetes, giving statin and SGLT2 inhibitor to each and every patient of diabetes, if there is no contraindication, will help in prevention of heart failure in diabetic subjects.
Yes, if the patient doesn't have a phimosis, male patient, we should for SGLT2 100% and for statin also, but I'll start with the low dose and see how the thing is happening. And patient compliance is a very important thing. So they should be more encouraged. The challenges come if the patient is younger, around 40s or less than that, what we do, and convincing them is a difficult challenge, but it's a task. না না কোশ্চেন নেই তো শুনে দেয়, আমি তো কন্ট্রোভার্সিয়াল কিছু বলিনি। ইয়েস স্যার।
In case of hypertensive patient, 68 years old, complaining of syncopal attack with heaviness in the chest, clinically it was diagnosed as transient ischemic attack. It was not found. But with the egosprin, patient is all right. What is your valuable opinion regarding that?
Giving egosprin has relieved.
Relieved. Till now,
No. So this is maybe a placebo effect of egosprin, but chest pain followed by
syncopal attack.
Chest
heaviness in the chest.
No.
Now he is absolutely okay.
Oh no, fine. That's the probability in this case is a coronary artery disease which is producing some arrhythmia. It's one. Second is intermittent atrial fibrillation. Episodes end spontaneously with a pause and then you get a syncope. Relieving with aspirin is a coincidence, so we need to...
He consulted cardiologist at Command Hospital. They are teaming with this stone also. Till now he is on aspirin and dyslipidemia, anti-dyslipidemia drug.
Fine. So, but we need to exclude this thing, arrhythmia and coronary artery disease.
Just one question, doctor. Excellent talk. I just want to ask you, there are a lot of obese patients, particularly ladies, they get breathless. And you do all the investigations, they're still normal. One or two I have tried to put on the ARNI and see, and they get improvement. What is your opinion?
I go with your opinion because that's actually the future. Shuananda has joined late, but never late. Shuananda, ashun. Amar chair e apnar thakar kotha chilo. Oh, tai. Okay. Thank you. আরেকবার repeat. চলো ঠিক আছে।
Thank you so much, Speaker. Sir, please be there. It's time to felicitate you. I would like to request the chairperson to please felicitate our speaker. Sir, please. Felicitation. Thank you so much, sir.